Acute diarrhea acts as the body's natural flush response to pathogens. In a clinical setting, the immediate life-threatening risk is the rapid, massive loss of fluids rather than the infection itself. This diagram shows the 4 red flag criteria that mandate bypassing outpatient care for immediate hospital admission. We assess for a systolic blood pressure under 90, an altered sensorium, severe dehydration presenting as oliguria, or the inability to keep oral fluids down due to vomit. When vital signs are stable and no red flags are present, we begin the standard rehydration protocol. We administer an oral rehydration solution at a dose of 200 to 250 milliliters after every loose stool. For patients with severe dehydration who remain stable, we initiate IV Ringer's Lactate. Checking these vital signs first is the baseline of the protocol. Skipping this assessment risks attempting to treat a patient in an outpatient clinic when they actually require the level of monitoring only found in a hospital. Once the patient is stabilized, we establish dietary rules. Instead of prescribing fasting or bowel rest, we instruct the patient to eat soft foods like rice, bananas, and yogurt to maintain their nutritional intake during the recovery process. This cellular-level diagram of the intestinal lining shows the biological reason we remove milk from the diet. Acute diarrhea causes a temporary loss of the lactase enzyme. Without that enzyme, milk remains undigested and acts as an osmotic agent, drawing excess water into the gut and increasing the frequency of stools. Sugary drinks like fruit juices or colas create a similar osmotic pull. We also restrict fried and spicy foods. The fats in fried snacks reduce gastric motility, which often leads to increased bloating and nausea. Providing these specific dietary restrictions prevents the patient from inadvertently worsening their own condition and prolonging the duration of the diarrhea. This comparison matrix defines the 2 primary pathways for clinical management. On the left is non-inflammatory diarrhea, characterized by watery stool with no blood and no fever. For these cases, we rely on ORS and can optionally include loperamide for adults. On the right is inflammatory diarrhea, identified by blood in the stool or a fever exceeding 101 degrees Fahrenheit. These cases require stool cultures and empirical antibiotic treatment with a fluoroquinolone. In inflammatory cases, anti-motility agents like loperamide are strictly contraindicated. As the inset diagram shows, slowing the gut traps invasive bacteria inside, which increases the risk of the pathogen burrowing through the intestinal wall and causing a perforation. Misclassifying the patient at this stage leads to 2 distinct failures, either the unnecessary use of antibiotics or the accidental creation of a life-threatening intestinal complication. Let's test these rules with Scenario 1, a 28-year-old male with watery stool, stable vitals, and mild nausea. This matches the non-inflammatory profile, so we prescribe only ORS. In Scenario 2, a 35-year-old female presents with bloody mucus in her stool and a fever. This is an inflammatory case. We order stool testing, begin empirical antibiotics, and avoid all anti-motility drugs. Look at this chart for Scenario 3, a 60-year-old male with watery diarrhea 10 times a day and a low-grade fever, who finished a course of antibiotics 5 days ago. Pause here and choose the correct treatment path, A, B, or C. The correct answer is C. The recent antibiotic use suggests a Clostridium difficile infection. We order a toxin or PCR test and begin oral phytoxomicin while ensuring anti-motility agents are avoided. This scenario highlights why we avoid an automatic antibiotic reflex. Indiscriminate use of antibiotics can trigger the very C. diff infections we are attempting to prevent. All of these individual clinical decisions are part of a single 5-step management algorithm. This flowchart tracks the process. Step 1, screen for red flags. Step 2, classify the diarrhea. Step 3, order tests. Step 4, manage rehydration. Step 5, follow-up. Final challenge, a 2-year-old child with 1-day watery stool, no blood, sunken eyes, and reduced urine output. Apply the 5 steps to this case. Determine the management plan for this pediatric patient and share your step-by-step reasoning in the comments. Standardizing care through these 5 steps ensures that every clinical decision, from initial triage to final follow-up, is grounded in physiological evidence and patient safety.